السلام عليكم ورحمة الله وبركاته. صبحكم الله بالخير جميعا. معكم الدكتور هيثم فقيه من قسم علاج أمراض اللثة والأنسجة المحيطة بالأسنان. بداية نود أن نهنئكم جميعا بعيد الفطر المبارك. سأل الله عز وجل أن يتقبل منا ومنكم صالح الأعمال وأن يعيد علينا وعليكم أعواما مديدة. محاضرتنا اليوم عن Periodontal Plastic and Aesthetic Surgery هي مقسمة إلى جزئين. جزء حناخذ نصف المحاضرة أو نصف المحتوى عفوا اليوم، والنصف الآخر كما هو مذكور في الكورس أوتلاين بإذن الله. أعتقد حيكون خلال الأسبوع القادم بإذن الله. طيب، بداية في حال أنا رفعت لكم محتوى المحاضرة بشكل كامل على البلاك بورد بحيث تقدروا تنزلوا وتشاركوا مع زملائكم، وأيضا تكتبوا عليه ملاحظاتكم واستفساراتكم. وفي حال رغبتكم التواصل معي إيميلي موجود ضمن الكورس سبيسيفيكيشنز. بالإمكان إرسال أي سؤال أو الحضور إلى الساعات المكتبية المذكورة أيضا في سبيسيفيكيشنز. محتوى المحاضرة مأخوذ من Chapter 65 من Periodontal Plastic and Aesthetic Surgery by Henrietta Kai and colleagues. احنا حنسوي simple review وحندخل في تفاصيل Periodontal Plastic and Aesthetic Surgery. So بداية كلكم تعرفون يعني من 431 الجنجبة Anatomy، لكن على بشكل سريع يعني في أجزاء مهمة تهمنا جميعا. أولها الفري جنجبة والجزء اللي يعني غير متصل not attached to the underlying bone. وبعدها عندنا جزء attached gingiva which is mostly keratinized gingiva. Okay, and it is attached to the underlying bone with collagen fibers. وبعدين عندنا mucogingival line. وبعد كده عندنا alveolar mucosa which is non-keratinized epithelium. Okay, so the gingiva itself is attached to both the tooth surface and the root surface through desmosomes. وتكلمنا فيها في محاضرة 431 إيش الأناتومي الكلفيكولار epithelium، الjunctional epithelium، ومرور الجنجيفال fluid through the gingival sulcus. Okay, the second terminology which is important اللي هو الفينوتايب. الفينوتايب في الشابتر هو مصطلح قديم نوعا ما، مؤخرا بدينا نستخدم بايوتايب. اوكي، لكن بشكل سريع عندنا 3 types of gingival phenotypes. عندنا thin ويجي scalloped، or عندنا thick ويجي flat appearance, or thick scalloped. Okay, and usually to determine between these different phenotypes there are different methods that can be used. One of them is using a periodontal probe through the gingiva, okay, in order to determine its phenotype and also to determine its thickness. So what are the types and why is it important that we understand the phenotype? Okay, thin scallop phenotypes are more prone to recession and gingival inflammation, and therefore might require some kind of reconstructive or periodontal plastic procedure in the future. So what are the methods of assessing a gingival phenotype? Well, we won't be using all of these techniques, but you need to know them because when you read research, a lot of these methods, some of these methods are used and you must be able to identify them. So in the clinic, we can use the direct measurement technique, and it's usually invasive because what you need to do is you need to anesthetize and then probe through the gingiva itself to determine its thickness, or non-invasive methods by using a caliper, Castro-Viejo caliper, and I'll show you a picture in a moment. Another method is to use a probe transparency method where you insert the probe in the gingival sulcus. This is a non-invasive technique but can only measure the thickness of the marginal gingiva. Okay, so through the sulcus, you cannot measure the thickness of the attached gingiva using a probe. Okay, Another method is to use ultrasonic devices. It's also non-invasive, but it's used mostly for research purposes, and it's a very expensive instrument. CBCT scans are also have been used for measuring the thickness. It's non-invasive. It's precise, despite I may disagree with this, because the role of CBCT is to visualize dense bone. It's not made for the purpose of measuring thicknesses of tissue, where this can be performed by an MRI. Also, this is an expensive tool and instrument. And it's not really available to everyone. So an example for a probe, there's many probes out there. Okay, this is just one of them. It's the Hue-Friedy Biotype probe. Okay, if you can see the white probe underlying the tissue, it's most likely a thin biotype. Okay, and green probes in the same manner. If the color is visible, it's a medium biotype, and blue, if it's visible, that means it's a very thick, it's a thick biotype. Okay, and if you cannot even see the blue, this is a very, very dense kind of connective tissue. You can also use your regular probe, but the problem is this is very effective when you see a pink, coral pink gingiva. But once this gingiva is pigmented, it becomes much more difficult to actually observe the color or observe the metallic metal of the probe itself. Okay, so this is a drawback to the use of a probe. So another technique, which is non-invasive also, is to use a castrohyaleal caliper, and this is usually done during research purposes or before treatment if you'd really like to determine the type of biotype. Okay, Khan et al. In 2010 determined that this was usually the gold standard. But remember, we talked about gingival pigmentation, and it might affect the way of how it appears. Okay, so what is important here is when you're using direct measurements using a caliper or a probe, should be the method of choice for a clinical assessment of gingival thickness in patients with high levels of psychological, physiological F1 gingival pigmentation. Okay, usually using a probe showed poor disagreement in direct measurements because it was affected by gingival pigmentation. So the recommendation is either to use a caliper or to perform transgingival probing under local anesthesia. And this will tell you what the thickness is. Okay? So what does periodontal plastic surgery mean? It's defined as a surgical procedure that is performed to correct, okay, or to eliminate any anatomical, developmental, or traumatic deformities of the gingival or alveolar mucosa. So if you notice, the words themselves are broad in scope, okay, and we'll go into detail what it means to eliminate anatomical, developmental, or traumatic deformities. So it's a very broad description of the procedures that are involved in plastic surgery. So why is periodontal plastic surgery done? Okay, we perform it for multiple reasons. Okay, it's either you have excessive gingival display, we need to do some form of crown lengthening. You have a patient who has huge gingival enlargement, either from drug-induced problem. You have high lip line or vertical maxillary overdevelopment. You have root surface caries where they need to be restored and then covered. So we can use it also for gingival root coverage procedures or to assist with prosthetic treatments, especially if you have an abutment with a short clinical crown and it needs to be increased in length. And it also can be performed to increase the amount of keratinized tissue, either around teeth or dental implants. And also be used to treat dentin hypersensitivity, especially when these patients have a gingival recession. So gingival augmentation is a procedure where the tissue is augmented with another tissue, okay? But there are two ways of augmenting the tissue. It's either you augment to increase the amount of attached gingiva that you have, or you augment the gingival tissue to cover a root. So there's two important things that you must differentiate between them. When we are increasing the width of the attached gingiva, the goal is not to cover the root surface. The patient has very minimal amount of gingiva, and therefore we are going to increase that amount, either by using a free gingival autograft, free gingival connective tissue graft, or an apically positioned flap, or many other techniques which we'll be discussing. Okay, so we can increase the amount of attached gingiva by obtaining a donor tissue that contains keratinized gingiva, okay, and it's placed either in a free form or used with a pedicle. And we'll discuss these terminologies as we move forward within the lecture. Do we need to have attached gingiva? Is it important? Well, there's an important study by Lang and Low which said that you need at least 2 millimeters of keratinized gingiva to maintain gingival health. One of that is going to be an attached, and one of them is going to be a free gingiva, okay? However, there's another study by Maynard and Wilson says that, if your patient has extremely good oral hygiene, performs maintenance, shows up for recall, we haven't seen that the lack of attached gingiva will result in a recession. But you need to know that you need at least 2 millimeters, especially with patients who have poor oral hygiene or prone to periodontal disease. Okay? So why do we have to have that 2 millimeters? As we said before, this is going to allow the patient to properly brush the tooth surface and the free gingival margin, and therefore enhancing plaque removal, and also improving aesthetics and reducing inflammation around natural teeth and restored teeth. Okay, because keratinized tissue is more, stronger than non-keratinized tissue. So always having it around tooth structure will maintain that long-term health. Okay, but if you have reduced, okay, or absent, this may, why did this attached gingiva disappear? Okay, you might have a periodontal pocket that's apical or close to the mucogingival margin, which is very, very deep. You might have frenal and muscle attachments, okay, that, you don't have any attached gingiva anymore. And you might have recession, okay, that causes denudation of root surface, creating a functional as well as an aesthetic problem. So recession, when you have recession, your attached gingiva has already disappeared, okay? So what is the rationale? Again, to summarize, we want to facilitate plaque control. We want to improve patient comfort, especially during eating and brushing. We want to increase the zone of attached gingiva to protect our natural teeth or protect our, prosthetic crowns, okay? And especially in orthodontic patients, we need to maintain the health of the tissue during orthotherapy. And also in patients to help prevent future recession, okay? So what are gingival augmentation, coronal to recession? So as we said, we have a procedure, a gingival augmentation to increase the attached gingiva, or we can perform gingival augmentation that is coronal to the recession. And this is basically a root coverage procedure. And we have many different techniques to cover the roots, and we will be discussing them with you in detail as we go along, okay? So one of the first, if you look at the slide here, you can see the recession is clearly visible, but there's sufficient amount of keratinized tissue. So what is this tissue? So this was a gingival augmentation procedure, but was not the goal to cover the root. The goal was to increase the amount of keratinized gingiva under this recession. And then another gingival augmentation procedure, which is a root coverage procedure, was performed where the whole tissue was coronally advanced, okay, to at least 1 to 2 millimeters above the CAJ in order to cover the root. So this is called a coronally advanced flap for recession coverage, okay? But if you notice here, we have sufficient 2 millimeter of keratinized gingiva, but we have a problem around this prosthetic crown. So this is the mucogingival line. It's in an area where we prefer to have at least 2 millimeters of keratinized gingiva. So what was performed? A free gingival graft was performed to increase the width of the attached gingiva. The goal here was not to perform root coverage. The goal was to increase the amount of free gingival graft. Okay? So, recession, this is the term itself, is the migration of marginal soft tissue to a point apical to the cemento-enamel junction, okay, of a tooth or the platform of a dental implant. Okay? So, why does gingival recession occur? Okay, it's been known now that as you progress in age, okay, your gingiva usually recedes due to the lack, the density of the bone reduces and it also resorbs. So people who are older usually have more prevalent gingival recession. It's more common in older patients. It's also been determined that males have more gingival recession than females, okay, and also the site and the surface, okay. The teeth that are buccally, inclined, you will have more. Crowded teeth might have some form of recession, okay. So the site itself also affects how the gingival tissue will behave, both short term and long term. So what causes it? So these are extremely important factors that we must know. So the etiology of recession might be due to traumatic toothbrushing, traumatic dental flossing, using tongue and lip piercing. Occlusal trauma itself might not cause gingival recession, but occlusal trauma will lead to bone loss. So you have a reduction in the height of the bone and the gingiva will follow. So once you have bone loss, you will have gingival recession, okay? And we also have inflammatory or pathological causes like dental biofilm, the calculus, periodontal diseases that are inflammatory in nature, morphological causes. زي ما قلنا في البداية, if you remember, we said a thin phenotype develops more gingival recession than a thick one. Patients who have bony dehiscences, and we also discussed this in 431, okay, malpositioned tooth is positioned too anterior. This usually happens when during orthodontic treatment where the tooth is moved outside of the bony housing. So you have this automatic dehiscence that leads to gingival recession, might be caused by frenal attachment pull, and again, orthodontic movements, poor crowns, open margins, leading to inflammation, and from inflammation leading back to gingival recession, and also RPD clasps, which are very well known to cause these kind of problems. Okay, so is all toothbrushing, causes a problem? Absolutely not. What we're talking about here is traumatic toothbrushing. Patients who brush maybe more than 5 times a day, or use a very bad technique, or use extensive force, or the hardness of the bristles. Okay, so this is why we recommend using a medium to a soft toothbrush, and we show them exactly how to brush, either using modified Bass technique or some other kind of techniques that are available and well known and recommended. Okay, so it's improper brushing is usually characteristic in the patient's oral cavity. Okay, we have like attrition in the CEJ in the form of a V shape kind of, and you can see the tissues are like kind of pulled. This is usually trauma from the floss itself. So you can identify it, as compared to recession that has occurred due to, let's say, a periodontal disease. Okay. Usually, gingival recession caused by toothbrushing are usually associated with non-carious cervical lesions. Okay. So, what is better, using a manual or electric toothbrush? Recent and latest systematic review says that electric toothbrush is usually safer, and it's also been found to reduce much more higher level of plaque and reduce also the percentage of sites that are bleeding on probing. So my recommendation is to always use an electric toothbrush, okay, but use it in a manner that is safe and using also the proper technique. Gingival recession might be, as we said, the tooth is placed outside of the bony housing. And orthodontic treatment, you can see the bone, the tooth itself is not within the bone itself, and therefore will eventually lead to some form of recession. We also talked about dishesences and the thickness of the underlying bone. Okay, this might be anatomical, developmental, or may be caused from periodontal disease itself. So once the bone resorbs in the form of a discescence, the tissue will usually follow. So discescence can be either anatomical, pathological, traumatic. I've seen this in patients where they put pens in their mouths, okay, and usually students during classes will usually put the pen in their mouth, or using toothpicks, okay, patients who likes to put them between their lips for no obvious reasons have been shown to cause these kind of problems. Freno pull is also associated. The pull of the muscle itself will eventually lead, especially development, if it attaches in a site that is very close to the gingival margin of adjacent tooth. Another cause, which is very common and very well known to you, the presence of dental biofilm and dental calculus, poor oral hygiene will eventually lead to these kind of problems. So what do we see? What do we see with gingival recessions? The patients usually come either complaining that they have root recession, leading they have root caries, okay, or they have erosions and abrasions on their root surfaces. Sometimes they come due to poor aesthetics, and especially in the anterior aesthetic zone. Some of them complain of dentin hypersensitivity and pain, and once you examine, you can see that the root is clearly exposed within the oral cavity. Plaque retention, presence of inflammation, okay, or there's a progression, periodontal perio-endo kind of lesion that may result. Okay, recessions are classified according to two systems. This is the Miller classification. It's a very, very classic. It was published in 1985. Almost 100% of all periodontists have been using it during the past few years for treatment, for classification, for diagnostic purposes, and also to determine the prognosis of treatment which will occur. So we basically have four classes. Class 1, the gingival recession does not extend beyond the mucogingival junction, and if you notice, interproximally there's no attachment loss. Same thing for class 2, but the recession extends to or beyond the mucogingival line. Once you go in class 3, we're starting to see interproximal bone loss, okay, and also recession on the buccal aspect, but not extending to the mucogingival junction. And class 4, you have a combination, significant kind of problem where the interdental bone is completely lost, okay, and you have significant recession, and root coverage is almost impossible in these kind of classifications. So usually in class 1 and 2, research says that you'll probably have a 70 to 100% chance of complete root coverage. In class 2, it's most likely going to be 50% chance. Okay, why do we use the Miller's classification? It's basically easy. You can memorize it. It's widely used, okay, and it's reproducible. Okay, that means if you see here, the reliability of this classification using 200 photographs yielded a substantial to almost perfect agreement among different examiners. So it's basically it's a reliable method to classify. Recently, however, the American Academy of Periodontology has adopted the classification published by Cairo, and it's summarized into basically 3 different types. We have a GRT1, a GRT2, and a GRT3. Okay, And basically, it does not rely on the interproximal bone, but rather it relies on the interproximal CEJ, if it's visible or not. So if you can see here, 1 and 2, usually in Miller class 1 and 2, we cannot detect the interdental CEJ. Okay, so there's no interdental attachment loss. But gingival with attachment loss, if you have attachment loss that is less or equal to the buccal site, this is a GRT2. Okay, and if you have the complex kind of recession where the interdental attachment loss, okay, is higher than the recession defect. Okay, so it's basically a simpler form of the classification. Okay, so what about the papilla? What about the papilla? Do we have a classification for the papilla? Absolutely. Okay, this classification by Nordland and Tarnow, Dennis Tarnow, was published in 1998. It's also an old classification where you have a normal interdental papilla that fully fills the embrasure space. Class 1, okay, the papilla lies between the contact point, okay, and coronal to the interproximal CEJ. So this is the CEJ. This is the interproximal CEJ. So between the contact point and the interproximal CEJ is classified as a class 1 papilla. Class 2, the papilla extends beyond or apical to the interproximal CEJ, but it's slightly coronal to the facial CEJ. Okay, is this clear? And class 3, which is usually the most difficult, the recession, the interdental recession, extends beyond, okay, or apical to the adjacent CEJs or the facial CEJs. Okay, so what about the 5 millimeter rule? This is a very, very, very important study. Okay, Dennis Tarnow, who published that classification, also determined that if the distance from the contact point to the osseous crest, the interproximal bone, is 5 millimeters or less, 100% of the time you will have an interdental papilla. So if you put 2 crowns here and you see a black triangle, that means your contact point is more than 5 millimeters from the interproximal bone. And the best way to correct that, so you can have full papilla, is to bring the contact point a little bit lower on these 2 adjacent crowns. This is a very, very important study that has significant, implications on aesthetic or prosthetic, let's say aesthetic crowns placed in the aesthetic zone, basically. Okay, so let's talk about the tissue. When we talk about free gingival grafts and connective tissue grafts, usually the most common donor site, okay, to harvest a free gingival graft or connective tissue is from the palatal-mastic category mucosa, okay, within the palate itself. If you look at the H&E staining here, you can see we have an epithelium, a lamina propria, some ready pegs, okay, and then we go into the submucosal layer, okay, and then right here we have the periosteum and we have the surface of the bone itself. So the epithelium is extremely thin, about 0.3 millimeters. And then we have a layer of lamina propria, which is mostly collagen type 1 and collagen type 3. And then we have the submucosal layer, okay, which is full of nerves and lymphatics and vascular supply. Okay, and it overlies, so we're going overlying the periosteum, معناتها انها فوق الperiosteum. Periosteum is a layer that is separating the bone from the connective tissue. And also, we have some glandular adipose tissues, okay, some mucus glands within this tissue. Okay, so what about the periosteum? لما نيجي نتكلم على البيريوستيوم اللي على البون سيرفيس، هذه طبقة مهمة جدا. اوكي، له جزئين، له جزء قريب attached للبون نفسه من الداخل، اوكي، نسميه the cambium or osteogenic layer، وبعدين في طبقة فوق highly vascularized fibrous layer. عشان كذا لما نشيل التشيو وما نشيل البريوستيوم دائما يكون في نزيف في الموقع. اوكي، إذا تركنا البريوستيوم على البون it is full of blood supply. Okay, and an outermost fibrous layer اللي هي مقابلة للسبميكوزا فيها composed of dense collagen fibers. طيب في حاجة ثانية لازم نراعيها قبل ما ناخذ أي تيشيو من البلت اللي هو الكورس اللي هو مسار الجريتر palatine artery يطلع عادة من originates من الماxillary artery itself الجريتر palatine which supplies the whole hard palate soft tissue. Okay, وينزل معاه أيضا nerve. Okay, من الجريتر palatine foramen the middle aspect of the third molar. Okay, لو تشوفوا هنا الديستنس شوفوا من التissue we always need to leave 2 millimeters and then we can harvest the free gingival graft, but we have to be careful. Okay, the greater palatine is about 8.7 millimeters from the mid aspect of the upper six and about 10.9 to 11 millimeters from the mid palatal aspect of the second molar, which is the 7. Okay, and it gets closer or it goes higher as we move forward toward the canine. Okay, so why do we need to take care of this? We don't want to injure this artery and then have a waste 15 minutes, 30 minutes of our session time just trying to control the bleeding here. There are many different techniques, but I think it's beyond the scope of this lecture. Okay, so how do we harvest the tissue from the palate? Basically what we're going to do, there's many ways of doing this. Okay, we can do a single incision, just one line, and then we place the blade inside and try to harvest this tissue. This is a very difficult technique. Okay, and it requires experience and a lot of training to get it right. We have a double incision technique. Okay, so basically it's a small square and then we can harvest the tissue inside. So we pull it up just like a slide. Okay, another technique is a triangular slide, and then we open this window and then we harvest the tissue. Some do it, in more square form. It's called the trapdoor technique, or the technique which I personally prefer is just taking a full square out of the area and harvesting the tissue. Okay. So what do we do to the donor site? Do we leave it exposed? Some people do. Okay, some people platelet-rich fibrin, phenytoin gel, hyaluronic acid, just to try to improve the healing here. And enamel matrix derivatives were in the research, but research showed that there's no added value of placing enamel matrix derivatives on this side. Okay, an easy way, which I like to do in my own clinic and practice. Okay, I use a stent to cover the donor site. It's going to protect the area during tongue movement, during talking, during fluid consumption, or eating. Okay, so free gingival graft, we use it to increase the keratinized gingiva. Okay, or to increase the vestibular depth. Okay, but we do not use it to cover the roots. Okay, ليش؟ لأن التيشو هذا لازم يكون على البيريوستيوم، يعني لازم في blood supply تحته في مكان الريسيبيانت سايت. اوكي، لما تحطه على الروت راح يموت النسيج. Basically it's gonna die. Why? Because there's no blood supply جاي من الروot surface. Okay, so we use free gingival grafts to increase the amount of keratinized tissue, and this is usually apical to the gingival recession. Okay, so we can also use it to increase the volume of the gingiva, to deepen the oral vestibule في patients اللي ما عندهم vestibule ونبغى نحط لهم complete dentures. So how do you increase? You basically perform an incision in the vestibule and we place free gingival grafts in the bottom, okay, to improve or to expand this oral vestibule. Okay, and also for ridge augmentation procedures. مشكلته انه لما نحطه في التيشو حيظهر لونه افتح من الانسجه المجاوره. اوكي، فعاده لا يستخدم الفري جينجيفال جراف للاستاتيك زون. اوكي، again برضه شوفوا its advantages: predictable, enhancing width of the keratinized tissue. It's applicable لما نبغى نشيل فرينم ممكن زي الرقعة تمام على التشيو keratinized. Okay, placed in the area of the surgery itself. Simple. It can be used for root coverage. I do not recommend this due to the lack of blood supply. Disadvantages كثيرة. Okay, blood supply is obtained only from the recipient site. يعني لازم نسوي partial thickness flab ويكون عندي periosteum على البون واحط التشيو عليه واتاكد انه ما في blood clot between them. الشيء disadvantage انه palatal donor site مكان ممكن يسبب الم ونزيف لعده ايام. وشوفوا هنا low predictability in attempting root coverage. هذه ماخوذه من البوك مباشره. اوكي، لكن حاول اعطيكم بعض المعطيات وبعض التجارب من عندي خلال السنوات الماضيه يعني ممارسه وعلاج العديد من هذه الحالات. I don't use it at all for root coverage anymore. I just use it to increase the volume of my tissue and to increase the amount of keratinized tissue. Okay. في طرق حلوة ممكن نزيد الكمية حق ال free gingival graft. We can cut it like an accordion. Okay, هذا technique was described also in the literature. في طرق ثانية أيضا نسوي strip. Okay, ناخذ واحدة صغيرة جدا يعني 3 millimeters by 5 or by 10 millimeters. اوكي، حتى ان احنا نصغر مكان الدونر سايت في البالت وبالتالي allow for epithelial migration and healing which is much faster. اوكي، انا شخصيا لو سمعتوني في البدايه احب دائما اخذ free gingival graft. تمام، يكون 3 إلى 4 ملي. لو ابغى اخذ الكونكتيف تيشيو اروح اقسمه من المنتصف. اوكي، الجزء العلوي اللي فوق اللي فيه epithelium وريتي بيكس هذا حيكون free gingival graft. اوكي، سماكته ما تزيد عن 1.5 ملي. والجزء المتبقي لي هذا السبنيوكوزا، هذا اللي حناخذه connective tissue graft. اوكي، اذا ابغى اسوي root coverage procedures بناخذ connective tissue graft. اوكي، لكن اذا بنسوي increase للamount of keratinized gingiva حناخذ free gingival graft which is the top layer. اوكي، انا usually dry the tissue مجرد اني اطلعه بهذا الحجم وبعدين احط 2 tongue depressors. شوفوا 2 wooden tongue depressors ونضغط عليها زي الساندويتش. اوكي، وبعدين ندخل البليد من المنتصف ونقسم التيشو الى نصفين. اوكي، في طرق جيدة لإغلاق الدونر سايت. أنا أحب أستخدم سيانو أكريليت لاير. أوكي، مادة مشابهة للسوبر جلو نحطها على الدونر سايت. في ناس تستخدم سوتشرز، في ناس تستخدم كولاجين بلاجز أو membranes، في ناس تستخدم periodontal packs. and my favorite بصراحة هو الأكريليك palatal protector اللي هو L6 retainer basically، البلاستيك اللي ينحط يلبس المريض لمدة أسبوع يحمي المكان. أوكي، في تكنيك قديما يعني في السبعينات شرح باي برنموليان. اوكي، شوفوا هنا ما نبغى نحط الفري جينجيفال جرافت، لكن وايضا ما عندك اتاتش جينجيفا اني اسحبها واغطي على الروت، فلازم نحط فري جينجيفال جرافت to increase the amount of keratinized gingiva. فهذه الحالة نادرة ترى تماما حقيقة ان الجذر تغطى بشكل جيد. اوكي، لكن أيضا بيبقى هذا دائما اللمب لو تلاحظون أفتح من المناطق المجاورة. أوكي، هنا مثال جيد لاستخدام الفري جينجيفا جرافت. أوكي، شوف الكراتينايز جينجيفا موجودة اتاتش جينجيفا فوق بس في لاك، راح زاد كمية الاتاتش جينجيفا. طيب كيف الهيلينج؟ هذا الهيلينج مهم ولازم تعرفوه. شوفوا كمية السوتشرز مثبت التيشيو وبعدين نجيب جوز ونضغط على الفري جينجيفال جرافت حتى ما يكون في بلاد كلوت. في أول 48 ساعة حيكون في بلازماتيك سيركيوليشن من البلد. في اليوم الثاني إلى الرابع حتبدأ البلد فيسلز تدخل في هذا التيشيو بشكل تدريجي. من اليوم الرابع للسابع حيكون في good attachment للبيريوستيال layer. في 10 days حيكون التيشيو fully vascularized، وخلال 3 أسابيع الكونكتيف تيشيو بيكون يعني well organized. لاحظوا مو هو mature ما هو ناضج لكنه organized يعني منظم. لازم نعرف the rule of 6. الابيثيليوم ياخذ له 6 ايام الين يكون developed وناضج. connective tissue ياخذ له 6 weeks والبون ياخذ له تقريبا 6 months. Okay, so this is our last slide today. Again, this is basically a blown up picture of what we were talking about. This is the palatal tissue, زي ما قلنا 3 to 4 millimeters. Take a full bite of the tissue وبناء على استخدامك or what the procedure is going to be إما ناخذ منه free gingival grafts الطبقة اللي ذكرناها أو ناخذ منها الconnective tissue graft. أوكي اللي هو submucosal layer. أوكي أشكركم جميعا على حسن الاستماع وأعتذر على الإطالة. راح يكون بإذن الله هذا التسجيل محفوظ للمشاركة بينكم، وفي حال رغبتكم للتواصل معي بإمكانكم ترسلون إيميل أو تزوروني في المكتب إن شاء الله. تحياتي وشكرا جزيلا لكم.